afternoon or morning, depending on where you are today. We're excited to see all of you here today at our first policy session. My name is Taiji Hill. I am with the Health Leads team, and I'm excited to have all of our speakers here today. Before we get started, we're going to just cover a few housekeeping items. Next slide, please, Kevin. Thank you. So we have language interpretation services available for anyone who prefers to hear this session in Spanish. To activate that, there's a little globe at the bottom of the screen that says interpretation. And if you click that and select your language, you should be able to access the Spanish interpretation. And I can attempt to say this in Spanish, so bear with me. Para escuchar esta presentación en español, hacer clic en el icono del mundo de interpretación y seleccionar su idioma. And if anyone who speaks Spanish, if that was horrible, please feel free to correct me. Okay, next slide, please, Kevin. So we like everyone, if you could take a moment to identify your preferred gender pronouns. You can do this by clicking the 3 dots at the top of your screen. So where you see your box, where you see your face or your name. And if you click on that, you'll see a rename option. And if you can just add your preferred gender pronouns right after your name. So that could be she, her, hers, he, him, his, they, however you prefer to be addressed. And if you are not able to do that, if you're on a mobile device, please just add it in the chat. So I'll give folks a second to do that. Okay. And then there is also an option to activate the closed captioning. And you can do this by looking at the bottom of your screen and clicking on live transcript, and then select show subtitle. Okay, great. And then finally, just to review our practice agreements, and we went over these as part of the welcome, but just want us to keep these in mind as we are in community with each other today. So please be present and accountable. I know folks are working from home, you may have kids, you may have pets, all types of distractions. Please take care of yourselves and just try to be as present and accountable as possible. Also, we welcome, kids or animals who like to make appearances throughout the session. So please don't worry about that. We encourage everyone to be brave and be inclusive. Take space and make space. If you find that you're asking a lot of questions or speaking a lot, just try to, keep that in mind and make space for other folks to be able to speak. And if you see an opportunity for you to contribute, then please be brave and share. And you can do that either through the chat or you can use the raise hand function. We'll call on you and then you can come off mute and share. And then finally, we are focusing on equity throughout the entire conference. And so be thoughtful about addressing racially biased systems and norms. And again, try to avoid being offended or taken aback by the experiences shared by Black, Brown, and Indigenous people regarding racism. Okay, so I will pause there. Are there any questions? Okay. Well, if everyone is all set, then I am happy to turn it over to Elizabeth Zerker, who will be our moderator for today's session.
Oops. Thank you, Taiji. I'm really pleased to be here today, and thank you all for being here as well. I'm particularly pleased to be able to introduce this session's panelists, Jennifer McClellan, Dr. Donna Benton, and Susan D. Morris. They're going to talk about the role state policy can play in supporting all caregivers, the differences between states' caregiver infrastructures and differences in rural versus urban locations, educate us about innovative state policies which support caregivers, and provide information and recommendations about how you can advocate for caregiving innovations where you live. They have a broad range of experience and will discuss policies and strategies that are relevant to issues facing people with disabilities of all ages, including children and seniors. This summit and the conversations we are having today are so important. The longstanding health and income inequities in this country led to the disproportionate impact COVID-19 has had on Black, Indigenous, people of color, and immigrants and people with disabilities, as well as caregivers. It is particularly timely as well, given the Biden administration's recent initiatives for home and community-based services and support for caregivers. The American Rescue Plan Act provides an additional 10% increase in federal matching funds for state Medicaid spending on home and community-based services. Also, I'll refer to that as HCBS. And this money is to expand, enhance, or strengthen and not supplant state HCBS services. And the proposed America Jobs Plan includes $400 billion in federal funds, which could increase annual spending for these home and community-based services in Medicaid by around 33% annually. The America Jobs Plan would solidify the infrastructure of the care economy by creating jobs and raising wages and benefits for essential home care workers. The plan also includes funding for the home and community-based services for people who would otherwise have to wait as many as 5 years because of Medicaid waiting lists to get the services that they badly need. There's also the proposed American Families Plan, which includes funding to provide direct support to children in low and middle income families by increasing access to quality childcare and to create a national paid family and medical leave program, among other priorities. In addition to these historic commitments, Senators Brown, Casey, and Hassan, and Congresswoman Dingell have proposed the draft Home and Community-Based Services Access Act, which would make HCBS mandatory Medicaid services available for everyone in every state without wait lists or caps. The proposal would create national minimum requirements for home and community-based services and make it possible to enhance those services and the long-term care workforce. So with that background and these opportunities, let me introduce our three panelists. Jennifer McClellan is a parent and healthcare advocate from Clovis, California. She advocates for medically complex and technology-dependent children and access to Medicaid home and community-based services. She has a quarterly column on issues affecting medically complex children in the California Health Report. Dr. Donna Benton is a research associate professor of gerontology at the University of Southern California. She received her graduate training in clinical psychology from the California School of Professional Psychology and was a geropsychological postdoctoral fellow at USC Rancho Los Amigos Medical Center. Dr. Benton is a licensed clinical psychologist. Her publications focus on research in elder abuse and minority caregiving. Dr. Benton is appointed to the Master Plan for Aging, a work group established by executive order of Governor Gavin Newsom. Susan D. Morris is the California Government Affairs Director for the Alzheimer's Association. Susan has directed statewide public policy and advocacy for the National Alzheimer's Association since 2013. Susan advocates for legislative, budget, and regulatory changes at the state capitol on behalf of the 2.1 million Californians directly impacted by Alzheimer's disease. At the state level, the Alzheimer's Association has secured key legislative victories in dementia training, physician education, and Alzheimer's research, raising more than $26 million to date through the Voluntary Tax Checkoff Fund. Susan is active as an appointee to Governor Newsom's Alzheimer's Prevention and Preparedness Task Force, chaired by former First Lady Maria Shriver, in addition to the Master Plan for Aging. And with that, I'll turn it over to Jennifer McClellan.
Greetings, my name is Jennifer McClelland, and I am a parent of a 10-year-old boy who has medically intensive disabilities in Clovis, California. I'd like to talk today about the system of care programs that exist in California, how they work smoothly to allow parents of children with complex disabilities to live safely in their homes and communities, and how other states can move towards the integrative system of care that California has. My goal as a parent and caregiver, you may jump slides. My son is tracheostomy dependent, which means that his airway is unstable. As medical technology has evolved, we have allowed the type of children to survive and thrive who previously could not survive. That creates a problem. What do we do with these children in order for them to have a life outside the intensive care unit? My son was institutionalized for 8 full months as an infant in a pediatric subacute facility. He was medically cleared and stable for discharge, but even in a state like California, it took that long to arrange the system of home care so that he could come home safely. At the time, we lived in a rural part of Fresno County, and the contracts to provide services guaranteed by state policy simply didn't exist in the zip code where we lived. Over the years, we ultimately just had to pack up and move to an urban area in order to access services. That was an option for our family. It shouldn't have to be something that people do. There are still many counties, especially in the far northern parts of California, where guaranteed services simply do not exist. When I work with families who live in those rural and mountain counties, I tell them they just have to move to Sacramento or the Bay Area. The services don't exist, even in a state where they exist on paper. And my goal as a parent and caregiver is to provide a safe and stable home life so that my son can live safely with our family and eventually transition to independence. Next slide, please. In order to access home and community-based services, children need Medicaid eligibility. Adults generally access Medicaid because it is a low-income program. That creates problems for children who are from middle-class families who simply cannot meet the income thresholds to qualify for Medicaid, but who still need the suite of services. Most states have waiver programs that allow the child's income alone to qualify them for services. Without Medicaid eligibility, no child will ever qualify to receive the amount and type of home nursing care that allows them to live safely at home. The rules on qualifying based on disability vary substantially by state. In most states, there's some sort of program on paper, but there are waiting lists, sometimes of more than a decade. In many states, families are told, your infant needs this care to live at home. We can get it for you when he's 12. That's simply unsafe. It leads to unnecessary institutionalization, unsafe care scenarios at home, and death. Next slide, please. On paper, California's home and community-based system works. We have the 3 prongs of safe home environments for children. We have well-funded EPSDT home nursing care. That is a federal program administered by the states that provides a nurse, usually a licensed vocational nurse, to provide direct one-to-one care to these medically complex children at home. Use of these nursing services allows parents to go to work, to care for other children, and to ensure that their children are safe and their medical needs are attended to. We need coherent school nursing policies. School-aged children attend school. We get into a whole lot of contract disputes between home nursing companies and every school district. So that's an area that could definitely be improved. California also has paid care hours for family providers, including parents of minor children, through the InHome Supportive Services program. InHome Supportive Services allows me, as a parent of a disabled child, I am precluded from the workforce because my son's medical care needs are so intensive and round the clock. The InHome Supportive Services program allows me to receive pay for his care, which keeps our family out of poverty and ensures that there can be a parent as case manager to make sure that all the programs work together. California has all these programs on paper. What we really need is seamless, coordinated, and easy access to all of these programs. We still see substantial barriers in who is told about these programs at the right time in order to ensure a safe discharge. There's nothing more shocking than running into a parent of a 10-year-old who has the same set of disabilities and no one has told them that the programs that could make their lives functional even exist. And that's a difficult fix. Next slide, please. The Home and Community-Based Services Act has the opportunity to bring the suite of programs that works in California to other states. Paid family care and professional home nursing care are two sides of the same coin. The sort of children who need nursing care in order to live at home also need paid family care to act as a de facto case management team. The availability of professional home nursing care allows parents to work, and paid family care keeps families out of poverty if they can't work because of their child's care needs. In all these scenarios, family care is the glue that holds non-communicative systems together. Thank you.
Thank you, Jenny. And I'm going to turn it over to Dr. Donna Benton.
Thank you very much. First slide, please. So today I really just want to take a few minutes to plant the seed for you about advocacy and ways that you could advocate in your community. I titled this The Art of Planning because when going through the planning process and doing advocacy, I tend to think of it like the lyrics from a Stephen Sondheim musical, and the song is called Putting It Together. And in the lyrics, it says this about when you want to make a piece of art, and I really think planning is a piece of art. It says, it has to come to life, bit by bit, putting it together, piece by piece, only way to make a piece of art. Every moment makes a contribution. Every little detail plays a part. Having just a vision's no solution. Everything depends on execution. Putting it together, that's what counts. Ounce by ounce, putting it together. So next slide. When we think about how we're going to come up with these grand plans when we're looking for advocacy, everything that you do, every piece that everyone contributes through coalitions, through discussions and talks, that really is how we go through the art of planning. And it will all come together. But we do have to have a plan, and so that we can help towards making solutions. In California, for example, and I'm going to go through a few examples, not outside of California, but things that we've been able to do. The first thing that we did toward trying to work to help bring about visibility for family caregiving is that we had a resolution that was introduced in our legislature so that we could put together a plan called what we called a report on family caregiving in California. And that coalition that came together represented not just the traditional people that you might think of, or people in aging services and maybe some from dementia services, but we also included members from other areas, like those that were interested in labor law, children's services, domestic violence. All of these people became members of the California Task Force because when you're trying to put this kind of coalition together, you have to think of alliances. You think of where we have common values. And the Caregiver Task Force that was developed about 5 years ago in California was the first to bring forth what we wanted as far as planning. And we were an alliance based in the value that we felt that we needed to, as our title says, pick up the pace of change in California around family caregiving. We came up with five solid recommendations that looked at financial support for family caregivers, having a way of assessing and identifying family caregivers. We felt that there was a need to equip caregivers easily with information. You wanted to make sure that caregiving is affordable, and this was discussed by Jennifer. So that's one of these values that you want to make sure that's affordable. You want to integrate it into the places where caregivers are likely to show up, which are within the healthcare system. We also felt that you should invest in current systems that you might have in your own state. So in California, we already have a 30-year-old system called the Family Caregiver Resource Centers that is significantly underfunded, and even about 10 years ago was cut by 73%. So we felt that there needs to be a reinvestment in systems and not just let old systems drop that have the experience. And number 7, there needs to be some way to monitor, to make sure that the plans and the recommendations that are put forth by any advocacy group are followed through. So this is kind of how we thought of this. And then one of the things that came across from many of the coalitions and alliances is that they really do start from a values-based concept through the alliance or through a coalition. And one of the key values is diversity and inclusion. When we talk about caregiving, we know that it's across the board, and it comes from many age groups, all the way through, from very young babies all the way through older adults, and that it includes many different cultural and ethnic groups, different incomes. So all of these, we wanted to make sure that those were woven throughout any committee that you put together. Next slide, please. So the other thing that we worked on in California is that we wanted to make sure that sometimes you invite other coalitions. So you have a coalition meeting with another coalition, but then you're really expanding that universe. And so one coalition that we felt was very integral and important to work with was what we have are the California Work Family Coalition, but probably in every state there's a similar coalition that's working on policies around work and family. And this is a coalition that really looks at community organizations, unions, and not-for-profits. But we really had that united belief that all people should have the time and resources to care for themselves and each other. So that value statement that came out of that coalition is why we joined from the Family Caregiver Coalition with a Work Family Coalition, because really we are talking about the value of people overall having time to care for themselves and for other people. Next slide, please. When the Master Plan for Aging in California was put together, I talked about in our values that we felt that you had to have some kind of accountability. With the Master Plan for Aging in California, that accountability is in the form of having a research agenda that continues to look at making sure that you have some kind of advisory consortium that makes sure that you're measuring the right things to see what progress you're making on your advocacy plans. They involve both private and university research alliances. I think having researchers from universities really brings in ability to sustain your advocacy. and they're able to have many, many generations that can stay, because you want your plan to go, it's not a 1 or 2 year plan. Our plans are like 10-year plans. And I think that that's important to be able to look at the research and continue to bring in cutting edge information. Plus they can look at data, and data is what helps drive policy, helps make changes. And that information, we understood the power of data when you looked at COVID, and when they began to look at who was more at risk. Because at first, if they didn't break it out by ethnicity, we didn't get any patterns of who the risk factors were. So data becomes very important as a piece of your advocacy. Next slide, please. Next slide, please. Okay. The other thing is so probably in your state, there is a coalition that is working somewhere in the area of caregiving and family caregiving. And one of the easiest ways, and there'll be a talk on this coming up after our talk, so there'll be more information, but I wanted to let you guys know that at least there's a National Caregiver Advocacy Collaborative, and this collaborative is actually building and informing interdisciplinary collaboratives within states. So we actually meet regularly to talk about what's going on in each state around the area of advocacy, and we share our experiences and expertise so that we can continue to advocate and learn from each other. So the idea is to really elevate the caregiving policy priorities and infrastructure. And there's a link here, and I think the slides are being shared, but you can go to the link on the National Caregiver Advocacy Collaborative and find out what collaborative or who's working on caregiving issues in your state, and join that. Go ahead, these are grassroots organizations. And if you don't have one, you can go in, and then maybe you're the one that starts that early collaborative to work together toward caregiving policies. Next slide, please. So let me just review what we can do when we want to put together this beautiful plan, this work of art, and our steps that we have to take to make it come to life. It's important to determine who should be involved in your coalition. And sometimes, like when we think of like, okay, well, I had struggles with an older adult, so I'm just going to have people who are interested in older adult in my coalition. And I say, think beyond the group that you're interested in. Bring in people with may have similar values, and reach out to other organizations. Sometimes we forget that it's important to bring in faith-based organizations and students. One of the things that we have in California is we have students against Alzheimer's disease. That might not be the exact name, but they are working on Alzheimer's disease, and they're interested in doing respite for family caregiving. Now, most of the time, you don't think of college students as ones who could be in a coalition or become the advocate around family caregiving, because they're in their 20s, but many of them have already been impacted by caregiving during their time. So bring in people that you may not traditionally have an alliance with into your coalition, and begin those discussions so that you can come to some common values. Of course, as I said earlier, please reach out to the National Alliance for Caregiving, because you can find what's in your state. You can learn how to start one. They have a toolkit on how to start a coalition in your state. And in every state, there is at least an area agency on aging that has funding for the National Family Caregiver Support Program, and that's called 3E programming. You can reach out to your area agency on aging and find out, just the first question is, what are they doing with those funds? How is it being used for family caregivers? And those funds include not only for caregivers to older adults, but also older adults who are caring for younger people, so like grandparents who are caring for grandchildren or other relatives. And so just finding out how is your funding in your state being used toward family caregiver can be the first step toward advocating. And then I always say, if you're concerned, you have an issue, find your voice, and maybe do an op-ed, write a blog, begin tweeting about it. In some way, get your voice out there, because you'll begin to network and find other people that are want to advocate and reach out to the elected officials in your state. So that's how you begin to start your advocacy. There are already coalitions and alliances to look for, and I hope that you're able to use these steps. Thank you.
Thank you, Donna. And now Susan.
Hello, everybody, and thank you so much for the invitation to join you today. I'm honored to be here, and I wish I could see the 83 participants who are in this session. Usually when we're in person, I usually start by asking if anybody in the audience has been touched by Alzheimer's or dementia, or has provided caregiving. And if anybody's comfortable in the chat to enter the name or who it is that you provided care for. In my case, it was my mom, Hope, lived with Alzheimer's. I know there are many people probably who are participating today who have an experience with somebody they love. Yes, and I'm seeing my mom, my husband, my dad. You're not alone. Your mom, Jean, Karen, your mother-in-law. Thank you for sharing that. Your grandpa. Thank you. So today I'm going to talk a little bit about dementia caregiving. And Kevin, we can move to the next slide. Here are just a few facts. For many of you in this audience, these facts are familiar to you, but no surprise, 2/3 of all caregivers are women. It's been said the best long-term care policy you can get is having a daughter. So daughters-in-laws provide a lot of dementia care in our nation. This condition represents 11 million individuals today in 2021 who consider themselves to be dementia caregivers. And if you had a paid job that required you to work 48 hours a week, you would be getting overtime. It is a very labor intensive, a labor of love, and it's labor intensive. Dementia caregivers report 48 hours a week on average. And in my case, something we like to talk about with the Alzheimer's Association. I was a remote caregiver, and many people don't identify themselves as caregivers if they're not living in the same household or in the same town. But I spent every Saturday driving, getting up at 5 in the morning and driving 2 hours to where my mom lived and staying there until 8 at night and driving home. So the hours are logged whether you're living in the same household or not. And even individuals who are caring for a loved one in assisted living or skilled nursing are still providing a lot of hours of caregiving. We know the tasks are intimate and extensive: bathing, dressing, and we know there are medical interventions that caregivers are asked to provide that in most states would require a license to administer. In the case of dementia, because it is a progressive degenerative disease, caregivers typically serve in that role for at least 4 years consecutively. Our combined value to the nation is $257 billion. So when we talk about major investments at the federal and state level, it all pales in comparison to what we're doing unpaid as family caregivers. No surprise, about 60% report high or very high emotional stress. And because Alzheimer's disproportionately impacts people of color, specifically African American and Latino populations, caregivers and individuals with dementia report bias and discrimination that interfere with quality care and access. And if you wanted to learn more, you can visit alz.org facts. We have a fact sheet there for every state, so you can learn about what's going on in your specific state by visiting alz.org / I guess that is facts. Next slide. So building off of Donna's theme, sometimes working in public policy and advocacy, we worry that planning efforts are pushing us away into a corner and saying, oh, you go over there and plan and leave us alone so you're not asking for things. But that's not been our experience in California. The planning has been very meaningful and it has resulted in tangible outcomes. So you heard from Donna about the task force on family caregiving. It translated directly to a significant budget augmentation for the Caregiver Resource Center network after their funding had been cut back significantly. In our master plan for aging, we're very excited in California right now. $2.1 billion is being reinvested in the system of aging and disability in this budget that's being considered this week. And that includes funding for caregiver supports in area agencies on aging and increased pay and training for in-home supportive services workers like Jennifer. Jennifer described the IHSS program. And then we also have the Alzheimer's task force in our state, and that has translated to $4 million for caregiver training that's being contemplated as we meet today. And I think in a lot of states, as you go forward with your work, coming out of the pandemic, many states are hit hard financially, and when the federal Rescue Act funds go away, we're expecting that state budgets will be hard hit and there won't be a lot of new funding. So this is a really good time to start planning efforts if you don't have them already in place, to use the time when there's a dip in your state's economy to plan well, to be thoughtful, and to come out with recommendations that can be activated when the economy comes back around. Next slide, please. I wanted to talk again, working with the Alzheimer's Association. We're a nationwide nonprofit. We work in every state. I wanted to share with you not such a strong California bias and talk about some of the really exciting programs happening in other states. I love the title in North Carolina, Caregiver Alternatives to Running on Empty, a project that's underway in North Carolina. In North Dakota, there's an assistance program for dementia caregivers. And what we find, the best programs for people living with Alzheimer's and dementia start upon diagnosis. In a perfect world, when a doctor provides a diagnosis, whether it's mild cognitive impairment, dementia, Alzheimer's disease, if at that same time they provided linkages to services and supports in the community and caregiver supports, so that immediately the family caregiver could begin tapping into information, resources, training, education for themselves. And this is what these programs do. In New York, there's a very extensive Alzheimer's Regional Caregiver Support Initiative. And the focus there, as it is in California, is on underserved and underrepresented communities, a real focus on people of color and rural communities. In Missouri, there is a structured family caregiver program, not unlike California's Caregiver Resource Centers. And Wisconsin has a link through their academic medical centers and diagnostic centers that connect people immediately with family and caregiver supports. We've seen some fantastic models where there are support groups and the individual with Alzheimer's or dementia is meeting in one room while the caregiver is meeting in another. And that free peer support is invaluable. You know, what a help that is at no cost. At no cost to the government, but it gets people connected with the very practical and help that they need. You know, for instance, you know, someone will say, I have a really hard time getting my husband to take a shower. And all of a sudden, everybody in the room says, have you tried this? Have you done this? What about this? This worked for me. You know, that's the kind of support that we're looking to give caregivers. And in the pediatric world, it's called anticipatory guidance, where we're told, this is what you can look to happen at age 1 and at age 2, and these are the developmental milestones. We really need anticipatory guidance for Alzheimer's because the average progression is 7 to 10 years, and people like to know what's coming next so that they can prepare. And that's something that's the Alzheimer's Association is working towards. And with my final slide, I just wanted to let all of the participants know that we're very proud of our helpline. The 800 number that you see here, 800-272-3900, is staffed 24 hours a day, 7 days a week by master's level clinicians. And we have services available in 200 languages. Our staff speak these languages, and when not available, we have supports we can bring in immediately. So anyone in the country can call this at any time and get the help they need. We find with, often the challenges that come with being a dementia caregiver don't happen 8 to 5, Monday through Friday, when offices are open, like the Area Agency on Aging or the doctor's office. A lot of things happen in the middle of the night. So we're always there for you, and we invite anyone who needs our services to please tuck this number away and use it. And we also have an outstanding website that has a real emphasis on family caregivers. We have chat rooms available, resources for family caregivers. You can enter your zip code to see what's available in your exact community. And we have a Spanish language website too, alz.org/Espanol, where all of the information is available to you in Spanish. So thank you again for the invitation. I'm so happy to be here and look forward to the questions.
Thank you, Susan. We have a question right away from Adrian asking about whether or not programs are only open to people with an Alzheimer's diagnosis. And I don't know if you can address that, Susan.
It's sort of a mixed bag. That's a great question. Through our work with the master plan, we think the more people that a program can serve, the better. There are unique factors for dementia and other conditions that we want to make sure are addressed, but the programs that I highlighted from other states typically do focus primarily on dementia caregivers, but they're often part of another program that serves a wider and broader audience.
I would mention that the Area Agency on Aging, even under 3E, it includes people caring for someone with complex medical issues. So it doesn't have to be dementia. And dementia is very broad, which does not always just include Alzheimer's, but it could be Parkinson's or ALS or MS. So you can think of dementia under that large umbrella. And so there might be some non-cognitive components. And so the area agencies on aging also can work with people that way. And then, of course, within your state, there might be other groups that are working specifically with non-dementia related illnesses.
Mm-hmm. And people with dementia have other conditions as well. So it's rare that an individual, most have other chronic conditions happening concurrently. So we want to look at the whole person and all of their needs.
Thank you. And then there are two comments. One mentions that children and adults with autism can have wandering as well, which of course, is true. And I will say in California, through our regional center system, as well as in-home supportive services, we have the in-home supportive services and other programs do support people, children and adults with autism. I don't know what state you are in, Susan. And then from Tambra, I think this is for you, Susan, what an example of the type of support the helpline provides?
Sure. So I saw in one comment too, it's really common for people not to be diagnosed, to not be told by their physician of their condition, to have their concerns dismissed. So most people reach us, we know there are a lot of people out there where there's something going on, but it hasn't been named or labeled, and they don't know where to look for support and the help that they need. But examples of the helpline, it could be as simple as, I think my mom is having problems with her memory and I don't know what to do next. And so we'll offer guidance about how to pursue a diagnosis, how to prepare for a doctor's visit, the questions to ask, the warning signs. So it could be getting somebody started. It could be a difficult challenge. It could be 3 a.m. and somebody says, my mom is awake. She thinks she's moving around the furniture in the living room. She thinks that we have to move out of the house. I don't know how to stop her. Should I call the police? Should I call 911? And the person would offer some suggestions about what to do to de-escalate the situation, to communicate what might be underlying that. Or someone might say, one of the advantages of our helpline is I could call and say from Sacramento, California, and I could say, my mom lives in Miami, Florida, and we want to get some help in the home for her. And they'll connect me with the local office and all of the resources in Miami and say, here are some home care options for you. Here's, what you should consider, and pass me off to a warm handoff to the office in Miami for distance caregivers.
Thank you. So the next question is for the panel generally and attendees. It's from Lynn Hollerman. I'm interested to know what the panel and attendees think about the concept of caregiving as critical infrastructure. What is the best way to make the argument that family caregiving is infrastructure and needs federal policy, as in the American Jobs Bill? I don't know if any of our panelists want to take that.
I'll just chime in and say, Susan gave you the statistics to show how much of an infrastructure the contributions family caregivers make. COVID has pointed out the infrastructure of caregiving for keeping people safe in their home. Many of the people who were not hospitalized were because they were at home under the care of a family caregiver. And we can look at the impact that caregivers have on the economy and jobs, with 50% of them working. And so if you take people out of the workplace, not only does that impact the current economics of our states, but also the impact on the long term for the person, everybody who ages. So we have a lot of infrastructure around caregiving, and also the growing older adult population. So that would be some of the arguments that we've made with at the national and local level.
And I'd like to add that caregiving as infrastructure relies on Medicaid eligibility. And to the extent that Medicaid is a means-tested program, we are essentially locking middle-class working people out of the care structures that they need. Home and community-based services need to address not only the provision of care, but also eligibility for that care, so that spouses don't have to be impoverished in order to avail themselves of the programs that provide in-home care through expanded eligibility and waiver programs.
And I would add too, what I think is so encouraging about using the term infrastructure is, I think there was a false belief for a long time that caregiving is intermittent and episodic, that it's, you just go pick somebody up from the hospital, bring them home, stop at the pharmacy, and then you go back to life as you knew it. And Jennifer's an outstanding example of, the long-standing commitment that caregivers make over, a lifetime, or, in the case of Alzheimer's or dementia, 4 or more years on average. And so you need to have a support system and an infrastructure behind people to sustain that. It can't be intermittent or episodic. And we know, people are going home from the hospital, earlier and earlier, someone used to have a 7 or 10 day hospital stay. Now it's 1 day, 2 days outpatient, and so much is being asked of family members of all ages when somebody's discharged from the hospital, and helping somebody to rehabilitate after, whether it's a stroke or a hip fall, a fall. We need that infrastructure underneath our caregivers.
Thank you, Susan. I'm just looking, there's great comments and questions in the chat. Jennifer, do you want to, you type something and respond in response to Maggie's comment? Do you want to sort of?
Oh, Maggie brings up a major issue in that parent and spousal care through programs like in-home supportive services is specifically excluded from Social Security. And that's an impending crisis of poverty for the women who have been acting as caregivers because the work, and it is work that they do, is excluded from the Social Security retirement system. These are primarily female caregivers, and they are giving 10 to 30 years of their prime working years into a system that can't count it as work credits towards the Social Security system. Nothing that can be done at the state level can fix this. We need federal acknowledgement of a pending poverty crisis for caregivers in retirement.
Thank you. I'm just going back through. Sorry about that.
Here, I can help out.
Oh, thank you.
Yeah. So we had someone also chatted in. I'm interested in structural level policies to support family caregivers. For example, at the federal level, Social Security credits for family caregivers. Is there any state level equivalent or any that you're aware of? At present, it feels like paid family leave is as far as we've gone.
I think that's what Jenny was speaking to, is that's an advocacy piece that needs to happen, because it isn't the case in California, which has a very, there are 600,000 people who receive in-home supportive services. Parents and spouses are paid family caregivers in that program. So it's a huge program, and it's a huge issue that needs to be addressed at a policy level.
I would also add that in terms of tax credits, at least in California for a while, we used to have a tax credit for caregiving where you could take a certain amount on our local state taxes. So there are bills that go through that look at just locally if you want to have some type of tax credit for your local taxes. That sunsetted, but we did have that before. Right? Yeah, it's not there anymore, Susan, right?
No, it went away. And I would just add, on the federal level, we're working, something that the Alzheimer's Association is working on is health system change through Medicare and Medicaid, so that family caregivers are identified as part of so if somebody is in the doctor's office, there are questions about, do you have a family caregiver, who, not for purposes of an advanced healthcare directive, but to bring the family caregiver into the team, and also to find people who don't have a family caregiver, because 1 out of 4 people with dementia live alone. So we're working on health system reforms in the medical system to bring family caregivers into that conversation, make them part of the medical record, and make them part of the care team. We also have a federal bill right now for caregiver supports for underserved and underrepresented communities, where there would be grants to community-based organizations working with diverse populations. In the case of Alzheimer's, there's a lot of stigma that needs to be overcome, and that's best done by small, local, nonprofit community agencies.
And I think that there was a question, we're almost to the end of our time, but there's a question from Allison Gray for the panelists about examples of advocacy efforts that address caregiving throughout all stages of life, from children with medical complexity and transition-age youth to adulthood and aging populations. And it's a big question, but I wonder if we have any thoughts. Jennifer?
Can I speak to this as a parent advocate? I think that the key is for parent advocates to identify that their children are disabled and that there are lifelong conditions. We see parent advocates frequently fighting for great programs for kids, and then we have this service cliff when the children turn 18 or 21. We need disability community solidarity between children and adults at all stages of life. And I think that parent advocates can play a key role in making their activism intersectional with the broader disability community. The services that my child gets when he's adorable at 10 should be the same services he gets, and I'm sure he'll still be attractive, but when he is an adult, he will need the same suite of services, and we need solidarity between children and adults in the disability community.
Well, I think it's a really important point to close out this session with. And Taiji, I was gonna turn it back over to you to wrap us up.
Thank you, Elizabeth. Thank you to all of our panelists for sharing both your lived experience as well as your professional experience. Thank you to the audience for participating and sharing your experiences and expertise as well. Kevin, would you mind sharing? Thank you. Thank you. So we are going to break now. I'm sorry. I can't see my screen. We're going to take a break now, and we ask that you come back and join us at 1:40 Eastern Time, 12:40 Central Time, 10:40 Pacific Time. And we'll have sessions for policy. It'll be designed for caregivers by caregivers. Equity will focus on a vision for the future of caregiving. The panelists will be caregivers. And the innovation track will focus on long-term caregiving, looking at the challenges and opportunities. Thank you all again for your time, and enjoy the rest of the summit.